This
I can.
conference will now be recorded.
All right. Hello, everyone. Good afternoon. This is Jose Leon, Chief Medical Officer for the National Center for Health and Public Housing. And good morning to you if you are on the West Coast. Thank you so much for joining us today. We are going to briefly discuss the use of information systems and technology to improve diabetes care. Before we get started, we would like to know who is on the line. So let's do like a quick roll call for today's call.
Hi, this is Trishna with Tri-Cities.
Hi, how are you?
I'm good. How are you?
We're good. Thank you so much. And thank you for joining us. Who else is on the line?
Hi, good morning. This is Sonia talking to Amaya.
Hi, Sonia. How are you?
Hi, this is Kathy Orchin from Zufall Health Center in Northwest New Jersey.
Hi, Kathy. Good to have you with us today. So
Hi,
who else?
this is Irisari.
Hi.
This is Irisari from Ponce, Puerto Rico Med Centro.
All right. How are you?
Fine, thank you.
All right. Is anybody else on the line? All right. And I received an email from a Rio Community Health Center. They are going to join us probably like in 10 minutes. They are running a little bit late. So let's see if we can get started. Probably 2 days ago, we went to HRSA, the National Center for Health and Public Housing was invited to go to HRSA to talk about one of the current and emerging issues in public housing, primary care, and in health centers in general. And as you know, diabetes is a HRSA priority. They are very interested in all the performance measures related to diabetes. And when I say that, I'm not only talking about the uncontrolled diabetes performance measure, the A1C greater than 9, but they're talking about taking a quick look or the the obesity rates and all the diseases that are linked to diabetes, like cardiovascular diseases or the other performance measures that health centers report every year. So I understand that every time the health centers have the on-site visit, they review the diabetes performance measures to see how you're doing and any programs that you are currently working on, or improving or trying to improve based on what your health center is reporting. So before we get started in this conversation, I would like to ask you like 3 questions. Specifically on diabetes, what is your health center is currently doing, and what if you have found that you have to make some changes to what you're doing, what you should be doing, and what changes are you planning to make to produce better processes and results. So I'm going to stop for a moment, and if there is any of the participants who would like to let the others what you are doing, and if there has been any changes or any new program that you're planning to put in place.
Hi, this is Trishna with Tri-Cities in Fremont. So for our organization, we actually have a wellness department that manages the diabetes, and that's what I manage right now. Is we have case managers, including RNs, LVNs, and MAs who do health coaching. So we work with all the diabetes patients in Tri-City, and we manage them with something called panel. So we follow up with them consistently on a daily basis. We set, time frames for when we're going to follow up, if it's depending on what their A1C number.
Okay.
So the higher A1C numbers get like every week or every 2 weeks, whereas the ones that are lower, like 8, will follow up with like maybe once a month to kind of make sure they're on track.
All
And
right.
then another aspect of what we're trying to target with the wellness called warm handoffs. We
Okay.
actually see the patients right after the doctor sees them. So we were able to do like counseling one-on-one, go over any medication changes, anything they're doing different, that their numbers came down, or if their numbers didn't come down, try to motivate them and give them the tools, what they need to do to improve their numbers. And then we also have a third part of it is where we hold diabetes classes once a month, and we have our nutritionist, our nursing go in there, and we do exercises, and we show them that, like, we'll take their A1C prior to them walking, and then we'll take it after, and we'll show them that not their A1C, their blood glucose will come down like maybe all the way like 10 to 30 points after taking a 10-15 minute walk. So we're trying to like hands-on show them how to change and improve their health. So that's what we're doing at Tri-City.
Thank you so much, Tricia. You broke up for a moment and I couldn't hear you well. What you do when you have a patient whose A1C is greater than 9? How often do you see this patient again?
We see them on a monthly basis, but we coach them anywhere from 2 to 4 weeks over the phone. We have a wellness coaching department.
All right. And you also mentioned that you offer tools for these patients. And when you're saying tools, are you referring to fact sheets and written information for the patient?
Yes, we're giving them fact sheets, as well as we're doing classes to show them hands-on how to change their health, like with walks and taking their blood sugars prior to walking and after, and showing them how with like a 10-15 minute, even a 20-minute walk would drop your blood sugars like by at least 10 to 30 points.
Okay. Now,
So we're just trying to do hands-on, show them. Go ahead.
sorry, no, go ahead.
And so then we also have nutrition, a big part of that, where we show them healthy demonstrations, give them recipes depending on their ethnic background, give them different recipes to include into their regular lives to kind of improve the type of food they eat, and then portion control is really big.
All right, thank you so much for sharing that. And I understand that you do all these classes and training when you have the patient in the clinic. How do you, or at least do you communicate with the patient either through your portal or any other electronic means?
So as of right now, we're not doing that. We had some issues with our portal, but we are starting a campaign in April with our care messaging, where we're going to be sending out care messages, and then have our coaches start to use their panels that they're working with to communicate with the patients on a one-on-one basis.
Excellent. Thank you so much. And is there anything in addition to the care messages that you are planning to include in your diabetes care? Any changes that you believe you will be making in the future?
As of right now, I've been with the organization 5 months, so I'm still getting to know quite a bit. That right now, the future is just the care messages with the campaign blast. It'll be like a 25-week blast of like healthy tips and other methods to help control your diabetes. And that'll be a 25-week campaign where they'll get messages through text messaging. That's the only thing at this point that I know of.
Okay. No, but this is very helpful, and I believe patients are going to benefit from getting all these messages and the classes and all the tools that you offer. And so thank you so much for sharing that. Anybody else who would like to share what you are currently doing to address diabetes, and specifically for the patients who have AC greater than 9?
Yes, so this is Sonia Tucker from La Maestra, and what we're doing is we're also doing something very similar what than the person that was just speaking was talking about, but we're using a clinical pharmacist. So, using the clinical pharmacist, the pharmacist can do the adjustment of the medication as needed if that she feels that it could be beneficial for the patient, and this is done in conjunction with the treating provider. So we have a clinic, a diabetic clinic, and the diabetic clinic has a clinical pharmacist, a provider, one one MA or two MAs, one RN, and a health coach. So the same people that have had hemoglobin A1Cs that are higher than 9 are also referred not only to the clinical pharmacist but also to the naturopathic doctor. The naturopathic doctor spends about anything between 30 minutes to an hour with the patient trying to do lifestyle changes and diet recommendations that will be followed up by the health educator and the health coach as well. We have implemented also after hours group classes for those patients that cannot come during the day because it's usually a complaint that, oh, I'm sorry, but I have to work, I have to provide for my family and so forth. So we decided to start after hour classes, and that has been pretty successful. We started in January, and so far we've had 2 cohorts, and the cohorts are as small as 20 patients, which I think is pretty big for a new cohort that had started. And we have about 85% of compliance rate with those patients. We have been able to see patients decrease their weight by 5 pounds in 4 weeks and keep it on so they're coming back to the second cohort just to follow up on their weight. And we are about to, something that we struggle not only with the hemoglobin A1C, but is with eye care. So something that we're working on is trying to get a machine that our MA will be managing, and she will be doing the exam, taking the pictures and storing forward and sending it to the specialist, because we have issues with the diabetic patients going to the eye specialist, and the eye specialist sending us reports for us to follow up. So that's what we're doing here in La Maestra.
Thank you, Sonia. That is very helpful. Now, Sonia, a couple of questions. In regards to the use of the clinical pharmacist, is medication compliance one of the issues that you could say that?
Yes. We did a study about 2 or 3 years ago where we realized medication compliance was a problem, especially for those patients with hemoglobin A1C higher than 9, because they have the tendency to be in more than one medication. Also, a lot of our providers, especially our mid-level providers, are a little bit more skeptical on adventuring new medications. So they have the patients on the regular metformin at the maximum level. So having the clinical pharmacist and having a tier idea of what medication the patient should be started on after completing or after trying metformin, for instance, it is very helpful for the provider, because sometimes the provider just maximize the amount of medication. The patient taking that amount of medication is not going to be compliant. So when the clinical pharmacy explains to the patient, maybe we can use a different medication where you might be able to take maybe less amount of times or less quantity and be as successful, we have seen that the compliance rate increases.
Great. That's excellent. And the other question, can you please clarify this? Because you mentioned that you have the clinical pharmacist and the treating provider, the RN and the MAs working as a group. Is this something that they do for each patient individually, or is part of the 20 patient cohort that you mentioned?
No, so the 20 patient cohort is for the after hour classes, which they also come to the diabetic clinic. So we have one specific day, which happens to be Thursday mornings, where we call all the diabetic patients with hemoglobin A1Cs higher than 9, and we bring them for diabetic clinic. So it is integration of, some kind of a specialty care into primary care. We have a group that is helping us to reviewing the care that our primary care providers are giving to the patients. So what they do is they bring it for their regular appointment, and then they're invited to the after hour classes, or if they want to come to the regular hour classes, because we also have classes during the day, they can also join. But what we notice is by opening the after hour classes, we have had a lot of success with the patients that couldn't come during the day.
Excellent. And the last question, the last follow-up question is regarding the retina camera that you mentioned. In the past or before La Maestra got the camera, what was the process? Did you refer the patient to an
Yes.
ophthalmologist?
We have two ways. So we refer them out depending on the patient's location. So we will have to use especially outside of our scope, or we have an optometry in La Maestra. The problem is we have different sites and they're spread around the county. So some patients have an issue transporting themselves to us, even though we offer transportation as well. But it depends on if the patient has to work or what the patient has to do. So what we noticed is when we were sending the patients out to the specialist in the community, we were not getting either the patient into the appointment, or the results wasn't coming back to us. So we realized that by acquiring a retinal camera, it's our projection, we're still in the works on that, might decrease the no-show rate for the specialist appointment and increase compliance rate for those patients.
Excellent. Thank you. Thank you, Sonia. Who else would like to share information on what you guys are doing or what changes you are planning to make in the future?
Okay.
All right. So let's move on. And there is a new document that is going to be available probably in the spring of 2019. The National Association of Community Health Centers is working on a toolkit that is going to have some best practices and some programs that have been useful for other health centers. And then one of the recommendations that they have in this kind of document, which by the way is in the process of being approved by HRSA, is the fact that they are asking health centers if somehow you are working with any type of diabetes registry. And these, as you know, these are some kind of applications designed to organize clinical information. There are early versions where you could register chronic diseases and other conditions. Specifically, it was used for either cancer or cardiovascular diseases. One of the main issues with this kind of documents, in my opinion, is that you have to do and add the information manually, and probably coordinate with or link to your electronic health record. So I'm just wondering if anybody has had any experience with any kind of registry for chronic diseases, and if there is anything that you're doing in regards to any diabetes registry.
This is Sonia from La Maestra. Registries are usually they're usually built in a lot of EHRs. In our case, we don't use the EHR for our registry. We have a registry that we pull directly from our population health management tool. We will have to first identify the patient and add the patient to the registry, which it can be done as a massive add-on, so that we're able to pull patients from that particular registry. The one that we have works fine for us. I have worked with a registry, not for diabetes, but for hypertensive patients, something very similar to what you're talking about from NAC about 2 or 3 years ago. It is a lot of manual work. I would suggest that if we can leverage technology and leverage our EHRs, we will have a lot. It will be easier for us because it's less busy work and we can be a little bit more effective.
Thank you, Sonia. That's very helpful. And what kind of information were you able to gather when you were using the diabetes registry? I mean, were you able to identify patients with
oh yes, absolutely,
hypertension?
Yes, so with in the hypertension one, there was a lot of information, a lot of demographic information, last hypertension, last blood pressure. The only thing that we couldn't, that I don't remember being able to do, was what kind of medication the patient was on. That was the only thing that I think that we're working on, and our part ended. It was pretty successful for us. We went from compliance rate that was about 62% for hypertensive patients, and we went to 72%. It is very useful. It's just a lot of work. I had one person and two people working in this registry. The one that we pulled directly from our population health management tool has everything, including the medication the patient is on.
Okay. All right. Thank you, Sonia. That's great. Anybody else has had any contact with any chronic disease registry or any tool that you use to track patients in addition to your electronic health record? All right. Thank you for so much. We're going to move on and to talk a little bit about the use of information systems to improve diabetes care delivery, and then how you are using your health IT and all the information technology to make the right decisions for each of your patients. Specifically, the connection between the care team and the information that they receive from your electronic health records. For instance, how you document your BMI screening, and how do you counsel patients, and how do you obtain information so the patient receives the best diabetes care in this case. Specifically, we're talking about developing pathways for gathering key data from patients, and specifically patient measurements like weight, BMI, blood sugar, and then transfer that to the point of care testing, or if you have any testing devices. So is there any action that you are trying to improve when you are using your information systems and to improve the care of diabetic patients?
I'm sorry, can you repeat that?
Oh, go ahead. I'm sorry, I couldn't hear. If you can repeat the question, Jose?
Sure. The question is there anything that you're doing to improve the communication, I guess, between your health IT and the care team, so the data that they are receiving is data that they can easily use when they have a patient in the clinic, and specifically anything that is related to the BMI, blood sugar levels, and all the information that the doctor or the nurse need when they have a patient in the clinic.
Perfect. Thank you.
This is Trishna with Tri-Cities. So with our quality department, they end up sending us staff and care lists. So what we try to do is we try to capture as much of the services they need in the appointment. So we're trying to improve our chart prep to make sure that if the patient comes in for diabetes, that if they need an eye appointment or they need to see podiatry, we're trying to get them to an appointment while they're in the clinic, or at least make the appointment for them to go and see the eye doctor or go. And we have at Tri-Cities in Fremont, we have optometrists here on site. We have an optical vision department. So it's easier for us to kind of get them into that appointment or to actually make the appointment for them.
Okay, and what information are you capturing? I mean, I know that everybody is doing BMI, blood sugar levels and all that stuff. Is there anything else that you are capturing when you have the patient? So there is all the information is captured and well documented while you have the patient?
So what we're trying to start up, which we're planning to start up in March, is the social determinants of health with our Prepare tool.
Mm-hmm.
We're trying to find out more information that what's deterring these patients from getting better or caring about their diabetes. So we're trying to get more into what other social factors to come into play, whether they're short of money to buy the healthy foods, or do they not have a safe place to stay, or are they having language difficulties? Just other social aspects. We're trying to kind of capture that and hopefully capture most of it by mid-year this year. We're starting this Prepare tool in March. And then from there, we're going to analyze that data and see what one or two of the major social determinants of health. We're going to try to target that and see if we can help the patients with that. Other referrals, whether it's behavioral, whether it's food insecurity, other factors that could, make them not care about their diabetes.
Okay. All right. And I'm sorry, when are you planning to have the Prepare tool in place?
We're planning to launch it with our patients in March.
In March. Okay. All right.
Yeah, so that's coming up in the next couple of weeks.
Great. Thank you. And Sonia, I understand the La Maestra uses, in addition to Prepare, another tool. Am I correct?
So what we've done in the past is we do use the Prepare tool. We've been using it for a little over a year. So for the person that was speaking, if you need any kind of guidance or any kind of feedback, let me know. I'll be more than glad to help you with that. Yes. So we have developed. You're welcome. We paid all the prices trying to implement the Prepare tool, so we know what works. We have an idea what works and what doesn't work. So what we've used for us is in a homegrown social determinants of health circle of care process that we have. And everything starts even before the patient becomes our patient, is when they're assigned to us. So we try to address any kind of social determinants of health that the patient might have. And we've used a tool separate from our EHR so that we're able to identify those patients or those clients that are going to become our patients that have social problems that could potentially interfere with them coming into our clinic to establish care. So, and that tool sits outside of our EHR, but we all have access to it, so we're able to see if there is any social services that should be added to the care of these patients before, during, and after they have established care. So that's something that we've done with our health IT. Also, we have implemented on our QI, so our QI department, our next-gen department, and our in our IT department, they work very closely, and we have we design our own quality dashboard that sits on top of our EHR. Our quality dashboard usually just turns red if the patient is due for a screening, is yellow if the patient was ordered the screening but it hasn't been completed, or is green if the patient has complete that screening. And the screening is not only, it's more towards HEDIS and UDS metrics, but we have also customized certain areas right there where we are able to collect some social determinants from that particular tool as well. So we're working very closely together so that we make sure that the transition between, or the information goes between the care team and the patient station and the health IT in a seamless way, and try to incorporate it within the workflow that the patient has in our clinic and outside of the clinic with our social services.
Excellent. Thank you, Sonia. Thank you for that information. Anybody else have something else to share with the group? All right. We're gonna talk a little bit about the diabetes data to drive improvement, specifically in regards to the discussion of the data that you receive, you know, and how often the care team discuss these cases and ensure that you are providing the healthcare or addressing the healthcare needs of your patients. This kind of quality improvement activities is part of the 19 program requirements. Health centers are supposed to have all these meetings and discuss some of not only diabetes but any other clinical performance measure. But the question is whether, since now diabetes is hers a priority, is whether you are paying more attention to the diabetes care, and if there are any changes in the frequency that you meet with your team.
This is Sonia, and for us, so we have a monthly quality improvement meeting where all the medical directors and the associate medical directors come, as well as the clinic managers and the head people for each department, that whether they touch or don't touch that diabetic patient should be aware of what we're doing and where we are. Not only we break down the diabetic patient by who has come and what hemoglobin, who has had a hemoglobin A1C, who has hemoglobin A1C more than 9, less than 7, or more, or between 7 and 9. Also, who's had LDL or any cholesterol panel done, eye exam, a food exam. So we try to break it down, and we do it by, in that particular big meetings, we do it by site specific. And then when what we are trying to do, we're not quite perfect yet, but we're trying to do is do it by provider specific as well. So we give providers their productivities, how good they're doing in general, by peer review, by data. So trying to do the this diabetes data down to the gritty detail, we're trying to do that per provider specific is a little bit of work for us. We're trying to find out a way that is a little bit more, there's a little bit less time consuming, so that we can give the provider, you know, or the care team, not only the providers, the care team, exactly the information that they're looking at. Right now, they're looking at, okay, how many of their patients have come and who has a hemoglobin A1C, who's compliant, who's not compliant, but not down to who's had an eye exam and diabetic food exam and so forth. That part right there, we do it by clinic specific. In weekly basis, the 2 clinics that have providers that are dedicated only for diabetes, And they meet the day before. They do a previously planning that is a little bit more extended or more extensive than the ones that we do for the regular patient that is coming for the regular appointment. So there is a previously planning there, and there is a post-visit review. After they're done with the clinic, they get together and they figure out, okay, so what are we doing that we can do better, or what could we what did we do today new that we should keep? And also something that I forgot to mention to you guys is we have also implemented a fiber scan for our diabetic patients to try to capture the possible NASH that will be eventually developed by those type 2 diabetics, capture those on time, and make sure that we use that as well to measure the progress that the patient could have by losing weight and changing lifestyle.
Thank you, Sonia. Sonia, question. One of the discussions that we had probably a couple of months ago with the team doing all the site visits to health centers, one of the issues that they found was that sometimes the reports on the clinical performance measures are not given to the health center board. I am assuming, Sonia, that La Maestra is providing information on diabetes and all the progress, right, to the diabetes board. I'm sorry, to the health center board.
Yes, we are.
Okay. All right, thank you. Anybody else who would like to chime in on this particular topic?
So for Tri-Cities, we also do a similar thing. We have the quality meetings once a month where our numbers are analyzed, and we're also trying to see where individually we can provide support to the providers whose numbers are not that good. We are able to pull data to see compliance rates by provider. So we do have a dashboard up front where we post compliance rates by clinic, because we have 5 locations. So we post and kind of let them know where they're at, and then if they need any additional support, the wellness team goes in and tries to help them, and maybe the warm handoffs are done more with those physicians to try to motivate their panel of patients. So we are doing some of that as well, what Sonia had mentioned.
All right, thank you, Tricia. What about our friends in Puerto Rico? Anything that MedCentral would like to add?
Well, we do the same. Our meetings are every 2 months in the quality meetings, and the one who are invited are the director of the clinic and the medical director, where I explain all the results from the EHR. All our data is from the EHR now. We're not using any sampling out. We're using Universe. And in May, we're gonna start using. We're gonna buy a few devices from Medtronic, so we can measure the patient, and all of that data is gonna go directly to our EHR.
All right, thank you.
That's what we do.
Thank you so much. Okay, okay, let's move on. The other day, we briefly discussed the use of online patient portals to provide information to patients, where the patients can have, some clinics are using even the patient portals to provide what we discussed recently in regards to resources and tools for patients. Specifically in regards to self-management and other resources where the patient can find information on nutrition and healthy habits and daily routines such as exercising, etc. The question is, how frequent are you using your online patient portals to provide this kind of information to patients, and whether or not you have found these patient portals useful to communicate with patients?
This is Sonia Tucker from La Maestra. We try. Our population has been a little resistant to the usage of the patient portal, and it could be because the the average education level of our population is about fifth grade, and we're very diverse. Nonetheless, we're not leaving it at that. So what we have done in order to try to leverage technology and leverage this tool is we acquired just a new tool that is a messaging. It can be a messaging platform as well as interfaces with our with the patient portal, and it can be managed from a different platform. The patient portal that our electronic health record has is a little cumbersome, so to be honest, we haven't been very successful at leveraging this, and it has to do with how complex it is for us to get into that and send the information, and even realizing if the patient is able to get it, see it, or even opens the information in there. So with this new tool, we're hoping that we're going to be able to send the same information and track who was able to access the information that we're sharing with them. So this is where, if anybody has any experience, I would love to hear from them and learn more.
Thank you, Sonia. And
like I said, if it's like, for example, a member that they come in, they see, I don't know, let's say.
thank you, Sonia. And Sonia, you brought up a very good point in regards to health literacy, and how sometimes the difficulty in providing tools to patients. In addition, San Diego has a very diverse population. You have people from basically from different corners of the world. And do you have, let's put aside the patient portal for a moment. Do you provide health education in different languages, I guess, and somehow tailor fact sheets to people from different countries?
Yes, we do. So for the people on the phone, that way you guys can have an idea. We speak 28 different languages and dialects. Our patients come, last time we counted, from 53 different countries, or maybe 63 different countries. So we do. In our health education, so each one of our paperwork, we try to translate it at least in the 5 top languages that we speak in the organization, which is Arabic, Somali, Spanish, and the other 2 I can't remember if it's Vietnamese, and there's Vietnamese, and there is a fifth one. So we try to not only translate, but also the health educator and the health coaches that we hire are people that speak the language and that have medical backgrounds. So they serve as a health coaches and as a cultural liaisons as well. Because what might work for one patient doesn't work for the rest of the patient, for all of the patients. It depends on their cultural beliefs and their cultural background and their level of education. So we've tried everything possible to accomplish it, to address that social determinants of health, because it is a social determinants of health, and try to bridge that gap. And when you add technology to that, it makes it even a little bit more difficult for us to do that. Nonetheless, I think because technology is here and is here to stay, I think we'll be, trying to leverage the different platforms that there are available. I think we'll eventually be successful at making sure that we're able to track what we're doing.
Great. Thank you, Sonia. Anybody else who would like to share the experience with the patient portals and what you're able to provide to patients through the portals?
Okay.
All right. So let's move on. We are going to talk a little bit about telemedicine and diabetes. Specifically, telemedicine is still an issue, I guess, because telemedicine has been always been used more in rural areas where there is there are some difficulties to get a provider, and in some cases there has been the use of telemedicine has been to consult with a specialist when you have a patient in the clinic. And recently, there are even some insurance companies providing some kind of telemedicine or consultation where instead of a patient going to an emergency room, for instance, they have access to a doctor and or to a provider, and the patient can get some advice. And this is, as Sonia mentioned, I mean, telemedicine is here and is going to stay. And I would like to hear from the health centers their experience on telemedicine, if there is anything that you are, or if there are some particular cases when you use telemedicine for patient with diabetes or any chronic medical condition.
So I'm going to speak on that as well, if it's okay. So telemedicine, as you described, doctor, we have used telemedicine to not only consult but to present the cases of especially for pediatric patients from the primary care to the specialist. But also we've used a new technology, it's a new platform that I believe we're beta testing. We're the beta test group, where we are getting the meters of the patients, and we are getting that meter in downloading all the information into a platform that gives us a reading or gives us an idea of how the patient has been done, not only by hemoglobin A1C, but themselves testing in regular basis. And it also tells us if the patient hasn't been testing. It gives us also, there is a logic behind it that tells us if the patient should have their insulin or their medication adjusted and how. It gives us just an idea on how that should be done. So it doesn't tell you this is what you need to do, because you have to also take in consideration that the patient might have a little odd number one day because it was stress or, whatever it is that the patient did. That's one technology that we're using. There is another technology that our clinical pharmacist is using, where the patient sends the information of their meter via electronic. I don't know exactly the electronic format that they send it, but it goes to a platform, and our clinical pharmacist is able to mine that data and figure out if the medication that we have the patient on is the correct medication. If it's not, how we can adjust that medication. And then she discussed that with the the treating provider, and the clinical pharmacist or the case managers will call the patient and adjust the medication as needed.
And is the platform coming from an outside vendor?
Yes, it's an outside vendor. The ones that we're using, one of the ones that we're using is called Melodus, and is a beta test platform that is out there. I particularly like it a lot. And is a health center that invented this platform, and they're based out of Southern California.
All right, excellent. Thank you so much. And Sonia, the Maestro is also using telemedicine for other diseases, right? The other day, we had a conversation about liver conditions, and you use telemedicine to discuss some cases with, specifically on Hep C cases with a specialist. Am I correct?
Yes, so we've done that. Now we have because not only is Hep C now, doctor, we also expanded to NASH, and our liver clinic has tripled the size. So yes, we have used telemedicine, especially because the person that heads that particular clinic, who is a GI doctor, it travels around the world. So we've used telemedicine, especially when he's in Asia or in Africa, to just present cases, and also for him to be able to help us read sometimes certain results that we're not sure, because they're a little bit outside of the scope of practice of primary care doctor. And also when we were implementing FibroScan, it was another area that we used him a lot to make sure that we were reading the FibroScan the correct way.
Thank you. Thank you, Sonia. You know, and there are other groups providing some discussions on diabetes, and this is something that I wanted to mention to the group. I am quite sure that you guys are familiar with the Project ECHO. And there is a group of specialists when you have a patient and you would like to have some kind of medical advice for these patients. The group is at the, and you can send an email if I'm not, the email address is endoecho@salud.unm.edu. This is the University of New Mexico. And they have, if you have a patient and you would like to have a discussion with a diabetes expert in regards to care or management for a particular patient, you can send any questions to this group. Participate in the sessions. You know, these are live sessions where you can get additional information. So I believe that this is very useful. And again, the email address is endoecho@salud.unm.edu. Now, this is regarding point of care testing. The other day we had a brief conversation with a health center, and specifically they were saying that in some occasions it's very difficult to get the A1C results, because sometimes you have to send the results to the lab, and it's gonna take some time to receive the results. So they were implementing what they called point of care testing, where they would be able to get the results while the patient is still in the clinic. I'm wondering if anybody has any service similar to these service that this health center mentioned.
Hi, this is Krishna again with Tri-Cities. We do have A1C point of care machines here where we do most of our A1Cs at point of care right here. So we are able to capture that data and then counsel the patient from the wellness department right after the provider sees the patient. So we're able to discuss their numbers, tell them where they're at, how they can improve. So we do that on most of our patients. Now, the patients who have multiple labs at that visit will sometimes opt to go to the lab, to get it done. So at that point, they'll do the A1C at the lab. But we try to capture that here because we're not sure, will the patient actually make it to the lab? Does their insurance cover all of the labs? We try to avoid all those issues and try to get the data while they're in the office with us.
Great. Thank you, Tricia, for sharing that information. Anybody else doing something similar?
Yes, this is Sonia again. This is La Maestra. Yes, we have what we call in-house testing. Mm-hmm. So it's on the same day. I do have to say, I have some providers that are not very key on using the same-day testing, just because they said that, their reliability and the specificity of the test is not as good as the one that they can get when the patient goes to the lab and gets a blood test and whatnot. What we have decided to do is we're going to do the in-house test for the patient that just walks in, either as a walk-in or that is a chronic no-shower or is homeless. If the patient's homeless, chronic no-shower, or just walks in, we'll do the in-house test. If we happen to have a patient that is compliant, that comes to all the appointments, what we have decided and we've done, we have established standing orders. So the patient will be, when we're preparing for the day, 2-3 days prior to it, we will call the patient. Our MA will make sure that tell the patient has to come the day before to go to the lab. That way, when the patient comes to see the provider has the results of those tests.
All right. Thank you, Sonia. And I need to move back a little bit and talk a little bit about new technology. The American Diabetes Association has added a new chapter in the 2019 standards of care in regards to the use of insulin delivery systems, the use of pens and pumps, as well as some very good information about the use of the glucometers and the glucose monitors. And Sonia, very early in this conversation, mentioned that one of the issues is health literacy, and then how difficult it is sometimes for patients to understand some of the instructions for this kind of new technology. I would like to hear from you guys the experience that you have in regards to educating patients in the use of either pens or pumps, if you have any experience in providing that information to patients, or if the patient has a glucose monitor or a glucometer, and the patient, how the patient can learn and use this in a proper manner. There is a health center in Puerto Rico, and I had a conversation with them probably a couple of months ago. They are one of the health centers doing better than the Healthy People 2020 goal. And when I was talking to the chief medical officer, one of the things that he mentioned was that they have an agreement with a with one of these glucometer providers, and they get this for their patients, and they learn. They teach patients to properly use this kind of devices, and he believes that by using this and patients being able to have a daily reading is a great way to improve the diabetes, the diabetes level. I'm sorry, the glucose level in diabetic patients. So, what is your opinion, or what is your experience with the use of these devices, and how you are educating patients to use these devices?
So for us, we have leveraged the clinical pharmacist, and also we have a case manager that is trained and is only trained on these particular devices. So what she does is, we've done the train the trainer, so we also have other case managers and health educators that are aware of how these devices work. But what she does is she gets trained from the clinical pharmacists and the pharmaceutical companies that will give these particular devices, and then she trains the rest of the rest of the health educator. So we, in fact, we bring the patient for an appointment. Once the patient is either on one of these glucometers, or the pump, or the syringes, or any of these new insulin devices, or the glucometers, we bring the patient in for a 30 minutes to a 45 minutes appointment with the clinical pharmacist, or the case manager, depending on the level of education of the patient. Sometimes the patient needs a little bit more of hand holding, and if we feel that the patient is not really grasping the concept, so we'll bring the patient back in a week to make sure that the patient is doing it correctly, and we have the patient do it in front of us, so that they show us. It's kind of like, okay, now explain to me what did you understand that I told you? So let's do it together. Can you please do it in front of me? So that we're able to correct technique, and we're able to correct any kind of misunderstanding that the patient could have while they have been taught by the clinical pharmacist, or the health educator, or the case manager.
Great, thank you, Sonia. Anybody else sharing some experiences with the use of technology?
So we do the same here at Tri-Cities, where we, if there is a new device, or an insulin pen, or a continuous monitoring glucometer, we bring the patient in and we do the teaching, and then we have them teach it back to us. And again, depending on their level of understanding, sometimes it takes more. And this is done by the wellness department because we have nursing in the wellness department.
Great. Thank you. Thank you for that information. And it's almost time, and I am going to be very respectful of your time. In the past, we've been talking a little bit about text messaging and other technologies that we can use to educate patients. So I'm wondering if anybody can share anything or any experience with text messaging. The other day, Saki Show, who is on the line, she is the Director of Research, Policy and Health Promotion here, the National Center for Health and Public Housing. She was sharing with me some information that there are some video games for children with diabetes, or with type 1 diabetes, that can be used, to teach these patients, about the disease, about how to get good care of the disease, and improve some habits for these patients. Anybody has any experience with text messaging or video games?
Hi, this is Silvia, Puerto Rico. The text messaging is the best way we find to communicate with the patient. They don't use very much the portal, so that's the way we are communicating with them, through the telephone and through emails.
And what information do you send to patients? Specifically, reminders or health education, or any about?
Reminder for appointments. If they miss an appointment, they're going to have the next appointment there, or a notice that they have to communicate with the clinic, so we can make a new appointment for them. Things like that. Education, the patient education is only in the patient portal.
Okay. All right. Thank you. Thank you, Silvia.
Welcome.
All right.
Hi,
And I'm sorry. Go ahead.
Oh, this is Joy from El Rio.
Hi.
And
Hi, Joy.
hi. I joined kind of late, but I'm here. So we did a campaign by text message where we pulled a list of people with diabetes who had had a visit but no A1C in the past 12 months. And we sent them a text message saying that they were due for labs, which we had pre-ordered, and that they would get a $10 gift card if they came in and had their labs drawn, and a follow-up appointment as well. And we sent it out right before the holidays in December. And we sent it to, I think, just under 100 patients, and we got 0 responses. So we're not sure if it was our timing was off, doing it right before the holidays, or it also took us quite a while from the time we pulled our list to get over some of the barriers of actually sending out the message. So some of those patients had been in independently in the meantime and had labs. So I'm not sure if the delay was an issue as well, or if there was some other thing going on. But that was our initial test.
Thank you so much, Joy. And and you're right. We've been we have the same experience about so when we send information very close to the holidays. It's very difficult to get a reply or a response. So I believe that that's an issue when we are very close to the holidays. Have you done anything after the holidays, Joy, just to make sure that that's not that was not the issue?
Yeah, not specifically for diabetes. We are doing, we've done a couple of flu vaccine campaigns that have been successful. We're actually gearing up to do another one for kind of a last push for this season. So we'll be collecting data on that, but it's not available yet. And we might circle back around to the diabetes one, but don't have any plans currently.
All right. Thank you, Joy. And the last item that I have in the agenda is the use of how to build partnerships to support quality improvement efforts. And this is a recommendation that is again coming from the toolkits that I mentioned in the beginning. This is a NAC toolkit, and then they are recommending health centers to get engaged and have this kind of conversation with primary care associations and ACCNs and other NCAs. I'm just asking this brief question whether or not you've been working with your PCA on any diabetes control effort. All right, and then there is a new site. This is something that the health center, the NCAs and NAC have been working for the last 6 or 12 months. And there is a new health center resource clearinghouse where you can get information on diabetes or any other topic where you, if you need any kind of information, and these are approved HRSA documents and publications, videos, webinars. If you do a Google search and type the Health Center Resource Clearinghouse, you can get the link to this place. It's currently active, and you can find any kind of information for any particular issue you may have, either a quality improvement or finance or emergency preparedness or any topic that you are looking for. If you have or you need any additional information about the clearinghouse, just send me an email and I will be more than happy to provide you additional information. So I want to thank everybody for participating today. It's been very helpful. It's always a great experience to hear from all of you, and thank you for sharing your experience, your best practices, and so other health centers can improve their quality efforts, quality improvement efforts, and everything that they are doing for the populations they serve. Once again, thank you so much for your participation, and have a great afternoon.
Thank you, Jose.
Thank you.
Bye.
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 I hope so.